This video discussion follows up a previous one covering methanol and ethylene glycol, the so-called toxic alcohols. Here we're going to be discussing antidotes for the toxic alcohols, namely ethanol and fomepizole, corresponding to Antidotes in Depth Chapter A33 and A34. The learning objectives for this session are that you'll be able to compare and contrast the use of ethanol and fomepizole as antidotes for the toxic alcohols, which will include specifically considering their mechanism of action, and to outline the dosing regimens of these antidotes. As covered in the previous video about toxic alcohols, methanol and ethylene glycol would be relatively innocuous if they never got metabolized. The first step in alcohol metabolism is through ADH, alcohol dehydrogenase, and if we block this step, we're going to prevent the accumulation of the toxic metabolites that can worsen metabolic acidosis and exert other serious toxic effects. Therefore, inhibition of alcohol dehydrogenase will be protective against methanol and ethylene glycol poisoning. The earlier we can block ADH, the better. But even if we block ADH later, as long as there is still some of the parent compound left, we're probably preventing things from getting worse. And this explains why we can use ethanol as an antidote. Alcohol dehydrogenase just likes to bind ethanol a lot more than it likes methanol or ethylene glycol. Ethanol is a naturally occurring compound through fermentation, so there's some evolutionary pressure to develop and maintain an enzyme system to clear it. And while the structures of methanol and ethylene glycol are fairly similar, there's no reason why ADH would prefer to bind to their structures over ethanol. So you can give a therapeutic level of ethanol which will outcompete either of the toxic alcohols, unless they're at just insanely high levels, just by being around and occupying ADH's active site. The therapeutic goal here is to maintain a serum ethanol level of about 100 milligrams per deciliter, and this would require 0.6 grams per kilogram of ethanol. But per the textbook chapter, due to multiple potential variabilities, we include a safety factor by giving a bit more, 0.8 grams per kilogram as a loading dose. The preferred method is to give the ethanol intravenously, with the loading dose given over 20 to 60 minutes as tolerated. Both 5% and 10% ethanol solutions might be used, although you'd obviously need twice as much fluid with the less concentrated solution. After the loading dose, you need to start an infusion to maintain a therapeutic ethanol level. The book chapter contains some tables that I'm not reproducing here, since you'll just need to look them up anyway in the case you're involved with a patient who needs it. But regardless of the dose predictions based on patient weight and their alcohol tolerance, you still need to monitor the patient frequently to see if the ethanol level isn't getting too high or too low, whether the free fluid they're getting is affecting sodium levels, whether they're developing hypoglycemia, etc. It's also possible, when IV ethanol is not available, to give it orally instead. The total ethanol dose is the same, 0.8 grams per kilogram, and if you were using 20% ethanol, which would be most typical distilled spirits diluted 1-to-1 with water or another liquid, that would be a dose of 4 milliliters per kilogram. Although giving undiluted spirits is not recommended, for reference, this is the equivalent ethanol content of about 4 shots or most of a bottle of wine. Since another treatment for toxic alcohols is hemodialysis, which many seriously poisoned patients will be getting, don't forget that ethanol too is removed by dialysis. So you'll have to increase the rate of ethanol going into the patient when you're increasing the rate at which it's going out. I recall one time during my toxicology fellowship when we had a fairly large patient, about 300 pounds, who was very sick from ethylene glycol and who was being dialyzed. I kept ordering more and more IV ethanol for him at a hospital where the pharmacy knew that we were a referral center for toxicology patients, and the pharmacists seriously thought we might have been diverting the ethanol for some other purpose, like drinking it ourselves maybe, because we were ordering so much of it. Now switching to fomepizole, the other main antidotal choice for toxic alcohols. The drug name fomepizole comes directly from its chemical structure, 4-methylpyrazole. Its brand name in the United States is Antizole, which is a portmanteau word combining antidote with pyrazole. Fomepizole has the same mechanism as ethanol. It inhibits alcohol dehydrogenase, but it is vastly more potent, such that we need milligram per kilogram doses of it, rather than measuring it in grams per kilogram as we do for ethanol. Fomepizole dosing also has an IV load, followed by maintenance IV dosing. The loading dose is 15 milligrams per kilogram. followed by 10 milligrams per kilogram every 12 hours for the first 48 hours. However, fomepizole induces its own metabolism, such that any continued dosing will need to return to 15 milligrams per kilogram. And similarly to ethanol, fomepizole is also dialyzed away. So if the patient is getting hemodialysis, the dosing schedule is increased from every 12 hours to every 4 hours. I imagine it's rare that you'd even have to take the autoinduction of fomepizole metabolism into account and change the dose. If the patient was sick enough to be dialyzed, this should probably be evident early in the clinical course, and the dialysis will be removing all or virtually all of the toxic alcohol before the autoinduction could occur. It's possible a patient might be diagnosed early enough that they weren't yet acidotic or with any end organ toxicity, and they were given fomepizole, but the toxic alcohol level was not high enough that the risk-benefit estimation favored dialysis. In that particular scenario, the patient might need fomepizole treatment for several days, watching the toxic alcohol level fall as it's excreted into the urine, either methanol or ethylene glycol, or breathed out through the lungs, methanol. There are a few adjunctive vitamin therapies that may help to detoxify methanol and ethylene glycol metabolites. There's little downside to using these therapies, and the details and dosing recommendations can be found in their own Gold-Frank chapters. For methanol, patients may be treated with either folic acid, vitamin B9, or folinic acid, also called leucovorin, to help detoxify the formic acid metabolite. And with ethylene glycol, thiamine, vitamin B1, can help detoxify glycolic acid, and pyridoxine, vitamin B6, can help convert glyoxylate to glycine. So that's it regarding antidotal therapies for toxic alcohol poisoning. I'll be seeing you around.